Hello, everyone. I'm coming to you today with an extremely important topic that affects millions of people regarding the use of compression therapy in venous and lymphatic disease, with particular emphasis on those patients that have both swelling due to venous and lymphatic disease, but they have arterial insufficiency, which means their circulation in the leg is not normal. And here it is absolutely critical to know the principles of compression and use them properly for the success of the patient. And this is such a complicated topic that I've enlisted one of my dear friends and colleagues who I've worked with a long time, who's now a foremost authority, both nationally and internationally, in the approach to venous disease and lymphatic disease. He's a vascular surgeon. Is Feder Lurie, who is Associate Director of the Jobst Vascular Institute and Adjunct Research Professor at the University of Michigan in Ann Arbor. Dr. Lurie's main clinical and research interests are venous and lymphatic disease. He's the leading researcher in this field, and he follows in the footsteps of the great Hugo Parsh that you can see in the background. We always pay homage to Hugo, who is the founder of modern compression therapy, and then his associate and younger partner, Giovanni Mosti, that's carried on those traditions and then taken them to a new level. And now in the United States, we have Feder Lurie, who was in Hawaii. Now he's in the United States, excuse me, and he's carrying on this tradition. And unfortunately, these principles aren't well known and practiced. So with that, Dr. Lurie, I'd like to welcome you to the program.
Thank you, Dr. Caprini. That was a very kind invitation, and I'm really honored to be invited to your program. And thank you for dedicating it to Hugo Parsh, who I believe first time laid down the scientific basis for the compression therapy.
Hello, everyone. Today, I'd like to discuss a very important problem regarding leg ulcers due to venous disease in the face of patients with reduced arterial inflow. Here is such a patient with a venous ulcer, and I'd like to dedicate this presentation to Professor Hugo Parsh. Professor Parsh was the foremost authority on compression therapy worldwide and practiced for many, many years, teaching these principles to all of us from around the world. We're indeed dedicated and indebted to Hugo for his efforts everywhere. He had such great humility and such an excellent speaking and teaching style. He will always be remembered. I have no disclosures related to this presentation. And edema in the leg results when there's a problem with normal venous return of blood. That may be due to venous obstruction, due to blood clots, hematoma, tumor, or other mass obstructing the vessels. Reflux, where the valves don't work properly, leaking both superficial deep and also the perforators. An increased venous pressure due to morbid obesity and other causes of increased intra-abdominal pressure. These factors can produce increased pressure at the venous end of the capillary, excuse me, and that inhibits the exchange of oxygen and nutrients into the cells and removal of waste products from the cells. These capillaries begin to dilate as the venous pressure increases, and that eventually results in cracks in the endothelial lining. And white cells are then activated in an attempt to seal these cracks. We'll see some videos showing this in action. Red cells are also trapped in these cracks, and thrombosis can result from activation of the clotting system due to the opposed subendothelial collagen because of the disruption of the lining of the blood vessel. Then the capillaries can no longer function properly, and skin changes, including rashes, eczema, and ulceration, may occur. Here we see a 1,000,000-power micrograph of a capillary, and you can see the tears in the endothelium because it's been over-distended in this laboratory experiment by the brilliant surgeon, Tony Camerata. And the endothelial cracks are secondary to the veins becoming over-engorged with blood. And as a result of that, blood clots can form in these damaged areas, as you can see here. And this process occurs when the leg veins expand and overfill with blood as a result of leg swelling or during anesthesia due to muscle paralysis when there is little to no blood flow out of the leg. Now, here is a white cell that changes into an adhesion molecule when the blood flow slows, as seen by the darkened picture. And this adhesion molecule will land on the surface of the capillary. And when it does, it will extrude granules, creating an inflammatory response that damages the wall of the capillary, making it useless to further transfer oxygen or nutrients. And then other adhesion molecules come along and join in the aggregation of these molecules. Here's the actual experiment where the adhesion molecule is about to penetrate the wall of the capillary, and another one right behind it. Now, another phenomenon that occurs when this damage occurs locally and cracks occur in the capillary wall, the white blood cells attempt to seal this leak. And you can see the cartoon here where they're attempting to seal the leak. And as a result of that, the flow in the capillary, although now the capillary wall the leak is plugged, the flow slows down due to the obstruction of the elements, fibrous tissue that heal the crack. And you can see that slows the blood flow down markedly and also still prevents the exchange of oxygen and nutrients. And this is a clinical scenario that represents that process. Now, if we take a look at, this is the valve in the leg, and this is an autopsy specimen where the foot is being perfused with saline and a scope is inserted in the groin into the femoral vein. And it shows the beautiful working of the femoral valve. And here is the same picture now with the ultrasound added on the left. And you can see how the ultrasound mirrors this anatomy in the vein wall and the valve. This is a large thrombus that's in the femoral vein, and you can see it's bouncing back and forth. And as you try to compress this with the ultrasound probe, it doesn't compress because the space is being filled with this clot. And this is what that is likely to look at. This is a damaged venous valve. It's the same view as the normal valve. And again, you can see the damage that occurs with the ingress of fibrous material that is triggered as a result of the clot. When clotting forms, clotting is not a body function that's in absentia. What happens is the inflammatory system is also involved, and that leads to the laying down of fibrous tissue, which varies in the individual, can lead to these venous valves. Now, what do we do about this? What is the management? Now, the physical characteristics of elastic bandages, Curlex, stockinette, TED hose, or tube gauze for leg swelling, venous stasis ulcers, or venous insufficiency-induced lymphedema is inappropriate and beneath the standard of care. Furthermore, the use of these products in the face of arterial insufficiency is not recommended. Now, we'll get into some details here. This is a short stretch bandage on the bottom and a long stretch bandage on top. Both were stretched to this level. And as you can see, the vast difference in stretching of the elastic material. And so this elastic material is a long stretch design, and there's it's of little value in controlling swelling. These bandages fail to produce hemodynamic changes conducive for ulcer healing, since the bandage gives way as the swelling increases. So it just expands, the leg expands, and finally until the saturation point, and then it results in a tourniquet type effect. So there's poor control of pain and tenderness in the leg, and they must be used in extreme caution when arterial insufficiency is present, because elastic compression produces a high resting pressure. It's like putting a rubber band around the leg. And also, because of pain and discomfort, it's difficult to wear day and night. Patients with mixed vascular disease, which means they have venous stasis and a venous ulcer, but they also have a impaired infusion of the leg with arterial blood being flow being slowed due to arteriosclerosis. Uh, these mixed patients represent a very difficult challenge. Now, here is a pico press measurement, which is a measurement that's put underneath the stocking or a bandage. And you can see as the person is lying down or stands or exercises, there's no change in pressure. So they have a very low pressure, which doesn't change. And as a result of that, you'll see some results. This is a leg that after a tibial plateau fracture that's been repaired with a big plate in the leg. And during the hospitalization, the orthopedic surgeon had ace bandages on this, and you can see the amount of swelling. And putting short stretch bandages on controlled this swelling in 1 day, and we'll talk more about that in a minute. Here is another situation where the patient has had ace bandages on a leg swelling, and you can see the indentation there. And here you can see it again with the pressure over the tibia. And also there's an ulcer forming here on the top of the calf as a result of this elastic bandage. Normal short stretch compression therapy completely corrected this problem. Here is another patient who had a graft and was put in an ace bandage after the graft. And when we saw this patient in the emergency room, we immediately converted the patient to a short stretch compression system and saved the graft and resolved the edema. Now, compression stockings are a little bit better, although they're still elastic, than the elastic bandage. And you can see here the pico press demonstration measuring pressure under the stocking. It goes up with walking and dorsiflexion and standing. And so we have a standing stiffness index that Hugo taught us, which is the difference between the lying pressure and the working pressure when standing or pumping your leg. And in this case, it's 5. Not really terrific, but better than the elastic bandage, which is 0. Now let's talk about the giraffe. Most people are unaware that the giraffes have venous pressure of more than 250 millimeters at their ankles. That's 3 times more than humans. However, giraffes do not suffer from lymphedema or venous disorders. They don't have leg swelling. Physiologists have discovered the answer is in the skin. Giraffe skin is inelastic, so it's like steel. It doesn't stretch. So as their leg muscles contract, the veins in the legs are squeezed, forcing the blood toward the heart. Thus, giraffes are not susceptible to problems like lymphedema and venous disease, even though they may be on their feet for 24 hours a day. It's just the opposite in humans. We have elastic skin. So what are the characteristics of a short stretch compression, inelastic compression, the giraffe leg type? There's a low resting pressure. You can put the bandage on without making it real tight. Just put it on firmly. And it's comfortable at rest. And when the patient ambulates, the swelling is reduced because the bandage doesn't increase in size, and it forces the blood to be pumped by the muscles out of the leg. And a standing stiffness index, which is the difference between lying and standing and walking, should be 10 millimeters or more for a good short stretch bandage. There's many different modalities: Una's boot, short stretch bandages, Velcro, and other strap devices. Now let's take a look at a typical short stretch bandage system. And this is four rolls on the leg, and then a co-band cover to stabilize the wrap. And these rolls are inelastic, and they can be used 100 times, because we usually give the patient these the first time, and when they come back, we have them bring the bandages back washed, and we can reapply them to the same leg without losing any of their tensile strength. And take a look at what we can achieve with a short stretch bandage system that I just showed you. The resting pressure in this patient is 60 millimeters of mercury, and the pressure goes up to 100 millimeters of mercury with standing and pumping of the leg. And what happens here too is that with the pumping action of the calf as the patient walks, it actually mimics a valve closure, and so incompetent valves are temporarily made competent and helps to blood to flow out of the leg. Now, as long as this pressure in the patient with mixed disease, the resting pressure is higher than 60, then it's safe to use this bandage. And here's another depiction of the same thing. And again, we see the tremendous increase in static stiffness index. And the rhythmic contractions actually close leaking valves, promoting flow out of the leg. So, appropriate short stretch compression is essential for healing venous-induced leg ulcers in the presence of reduced arterial inflow. You must make sure that the ulcers are not associated with arterial ischemia, which means the ankle brachial index, which is the pressure in the arm versus the pressure in the leg. If it's less than 3/10, then that's an ischemic leg, and you cannot use compression on that leg. Superficial venous reflux may have to be addressed with venous ablation procedures, and applying short stretch compression modalities measured to apply resting pressures below arterial inflow values are mandatory. The blanket rule not to compress legs when the arterial brachial index is 0.5 or less, not necessarily true, because if the patient has a 180 systolic pressure in the arm and 90 in the leg, that would be 0.5. But if you put a bandage on that has a resting pressure of less than 90, let's say 40 or 50, then that's safe to use in that leg. And here's a typical ulcer that was untreated for months. We treated this over a period of a total of a year with short stretch bandage, frequent debridement, and finally application of a skin substitute. And here's another case with a superficial venous insufficiency before treatment. And in this particular case, the patient had bad varicose veins with superficial venous insufficiency. And here are the pictures of the scan, the duplex scan, showing these large varicosities and the marked reflux. And this is a healed ulcer 6 weeks after venous ablation. So that's another important feature to remember about these legs with a superficial venous insufficiency that has to be ruled out. Let's talk about Velcro compression. Velcro compression is the mainstay of most of these patients with mixed disease. And these are devices that don't stretch. They have a low resting pressure, a high working pressure. So as the muscles contract, blood is forced out of the leg since the bandage doesn't give way. This results in decreased residual venous volume and edema, and the static stiffness index of greater than 10, which is ideal for treating edema and ideal for patients with mixed vascular disease. Here's a typical picture, 40 underneath, 40 resting pressure with toe tips and standing and walking. The ambulatory venous pressure is actually reduced, and the pressure in this leg eventually stabilizes, and the blood is forced out of the leg because of this phenomenon. These indications for these Velcro devices include age, weakness, arthritis in the hands and shoulders, obesity or advanced pregnancy, restricted mobility, lymphedema, edema uncontrolled with conventional stockings, and leg wounds where the treatment with compression bandages not tolerated or feasible. Ulcer patients frequently with arterial insufficiency benefit with this Velcro compression. Here's an example of some different manufacturers' devices. You can see here one device, here's another device, and a third device. And you will also notice that the boot on the leg helps to control swelling in the leg and in the foot. And here's an actual patient with severe venous insufficiency, arterial insufficiency, past history of DVT, post-thrombotic syndrome, and ulcers. Also lymphedema. See the swelling over the dorsum of the foot. this patient was treated in a fashion similar to this other patient. Now, this patient had the same problem and picture as the last one, but was a different patient. And it took a number of months, but using Velcro devices plus appropriate lace shoes, we're able to rehabilitate this patient and get them back from being on disability to working full time. Another device which is out is the Cercade Cure, which is particularly useful in patients with healing ulcers instead of using compression bandages. They can be removed for wound cleansing and reapplied to exact leg pressures without special expertise. And they also can be fitted in the office without the need for sending patients to a special fitter. And in some cases, they may have economic advantages. Now, the device can be cut. And here it's been cut to the patient's dimension, and then the Velcro strips applied. And here is what it looks like on the patient. And you can see that there is a measuring device, and the measuring device can be lined up with these marks in the leg, and that will give you the pressure so that you will know the exact pressure of the device. So it's an ideal thing. And of course, it can be taken off and the patient can wash, and then it can be reapplied to the exact same pressure. And as you can see, it'll even fit into a dress shoe if it's done properly. So now, using compression in the face of arterial insufficiency, it's a must to measure the resting pressure. And values of ankle brachial index of less than 0.5 can be cautiously tested depending on the baseline pressure in the leg. Velcro devices are almost the universal choice for these patients because they can be applied. If the patient has any discomfort, they can be immediately loosened. And there is a patient measuring system if the Cercade Cure is used. And the bandage pressure, of course, should be below arterial pressure. One problem I've noticed with these is sometimes you'll put them on a patient, or the patient will get them and put them on, and then say, "Doc, by later in the day, they'll start to fall down." Well, of course they do, because the swelling in the leg has gone down, the leg volume has gone down, so they just have to be retightened as the day goes along. So that's a very distinct advantage and a much greater advantage than over the wraps. Don't forget that they can always be immediately loosened for any leg discomfort. And these are the various measuring systems. The Pico Press is a bulb-like device that goes underneath the compression stocking, bandage, or Velcro device. And it can be measured on the monitor, and then that monitor displayed on the computer, and you've seen some readouts of that. It's a relatively expensive system, and a relatively cost-effective, inexpensive system is the Juzo pressure monitor, which is also very good and measures the pressure underneath the bandage system. This is a must when dealing with patients with arterial insufficiency. And this graph shows how when short stretch compression is used, that it changes the digital perfusion pressure in the leg very, very little. So it's a very safe for ulcerated limbs. Remember, if the pressure is below 40 millimeters of mercury resting, that is a danger signal, and we have to protect the patient and not use compression in that particular situation. So in conclusion, understanding the difference between short and long stretch compression is a must. Avoiding elastic bandages in ulcer patients, especially when arterial insufficiency is present. But I've shown you that any of these patients with ulcer and swelling do not benefit with elastic or so-called ACE bandages. Complex duplex interrogation of the leg is mandatory in these patients. You've got to do an ultrasound to make sure that the ulcer isn't related to superficial venous insufficiency, and therefore varicose veins need to be treated. Rule out ischemic ulcers and also superficial venous reflux before applying compression. Another thing is, which we hadn't mentioned, but in patients who have chronic ulcers, one has to rule out a marginal ulcer, which is an ulcer that can actually be cancerous in a burn scar. And the Cercade Cure and similar Velcro products are ideal in patients with mixed disease. Measuring under bandage pressure is required for compression in these legs. Intermittent pneumatic compression devices may be an additional modality to consider in these patients. So I thank you all for your attention to this video, and please visit my website for more information. And I hope you all have a great day. Thank you very much.
You asked me to reflect a little bit on your lecture and the issue. You have started your talk with describing the causes and the mechanisms of edema in patients with chronic venous disease. Well, I think that identification of the specific etiology of edema in each patient, and I would say in each leg of a patient, because it can be different in different legs, is the key element of patient's workup, which appropriately emphasized in your lecture. Depending on the etiology, the specific involvement, specific venous segment, and treatment plan will be different, but it always will include, or most of the time it will include compression, either as a sole treatment or as adjunct to intervention. And that's, by the way I describe it is a logic of CAP classification, because if you know the C and E and A and P, you can make a solid plan, including the compression and the place of that. And with very few exceptions, patients with venous edema need compression therapy, even in the presence of arterial disease, as you said. And I would say especially in the presence of arterial disease, because the studies had demonstrated that use of compression therapy in patients with mixed ulcers improves the oxygen supply and oxygenation of the tissue, in addition to addressing the causes of swelling like lymphatic and venous. It is so, but the use of compression therapy in such patients is tricky, as you pointed out, and requires specific knowledge of perfusion pressure and knowledge of how much pressure you apply. And so you will not exceed perfusion pressure when you apply the pressure. And you actually described very nicely that there are very practical and inexpensive tools to use that, to know what the pressure you apply and so forth. But what I would like to emphasize, what I specifically like in your lecture, is addressing the issue of selection of what kind of compression devices you're going to be used. Because in my experience and experience in many people, when you see patients first time, it's almost universally you have them in either ACE bandages or compression stockings or some other forms of elastic compression, which is not the compression that they need. And specifically, point that you made, and I again want to just reemphasize for anybody who is listening to this, is a use of adjustable devices. Because even if you measure the pressure, if you know the pressure initially, it's going to change. The swelling going to change, the patient's going to move, it's going to change. And it needs to be adjusted. And I believe that the best instruments to make this appropriate adjustments are the patients themselves. So if you educate them and you explain them why to do it and when, they will do the best job, and not only secure that the pressure is applied properly, but also increase their compliance. So I think it is extremely important issue, and I just want to thank you very much for addressing this issue in this excellent lecture. Thank you.
Thank you very much, Fedor. The other problem we have is we can't go around yelling and screaming and criticizing and stuff like that. Those tactics just don't work. We have to find subtle ways to nudge physicians and other healthcare providers that are important, especially physician assistants these days and nurse practitioners, about the proper principles. And this is a really difficult thing. Could you give us some idea of your suggestions in how to create these subtle nudges to get people to do what they really need to do?
To be honest, of course, I don't know the answer to this question, but I can suggest that, and you actually touch it right in your question, that you mentioned the advanced care providers and nurses. Well, in reality, those are people who actually apply compression every day. And what I think is absolutely needed to focus our educational effort on this group of people and explain them practicality of what we're talking about. Well, given that, we have scientific evidence, they're not extremely good, but they're sufficient to tell what we know. But more importantly, we just need to give them the practical aspect. As they see the patient day to day, they will see that they are doing the right thing. And that, I think that's the only way how to learn. It's slow. It's maybe not as effective as I dream, but I believe that's what we need to do.
Yes, absolutely. And I don't know the answer to that either. And I think that one of the reasons that I've taken the trouble to put this together and put this together with you, this presentation, is that being on YouTube, often people will look at it even out of curiosity, and that can lead them to further pursue the topic. And today, especially the young people, they're used to doing things online. And so I think in a way, I'm hoping that this video is a possible nudge to answer that question as to how to get people to do what they really need to do and use the appropriate tools under these circumstances. So again, Fedor, I'd like to thank you very much for helping me with this and supporting me. And I wish you all continued success. And you need to carry the torch forward in this area of venous and lymphatic disease, as you are already doing now. Thank you very much.
Well, thank you for the opportunity to be with you on this channel.
Thank you.